my thoughts are about the biggest public health events I can think of at the present time. It would be to figure out how to improve parenting skills across the country. And the low-hanging fruit there is that huge piece of the population, tens of millions of people, who have personally had no experience growing up with supportive parenting, many of whom might do better if they only had depicted to them what that looks like. So the question in my mind is, we may be beginning to work on this, but if any of you want to compete, for God's sake, please do. We may be working on developing a pilot program for a television show that would have woven into its serial storyline illustrations of what supportive parenting looks like and how it plays out way downstream, contrasting that with illustrations of destructive parenting and how it plays out downstream. I will stop there. I believe we have some time for questions. And while you're getting at that, let me see if I can put up the last slide. Get it up again. There's some information on sources who follow up information.
I found your first question.
Dr. Felitti, you left us with a slide about the propensity to be raped. Would you care to comment further on that or ask us about it? The association with the higher ACE work with the more likelihood of being raped.
Well, what could one do to stimulate the integration of what we have learned here into everyday clinical practice? That would be my answer if I'm understanding your question correctly. A couple of other possibilities, and one of which I hear, I just heard an hour ago, is going to be starting soon here, would be to develop a really comprehensive medical history questionnaire that will be tested in, I think, with 17 counties in Oklahoma. So that information would be made available without request to every physician in the state who is seeing these patients. Essentially, that appeals to me greatly. Essentially, it's using patients as a market force to try to force a need to change in medical care practice, to make people aware of these issues.
So I noticed that there's a lot. Thank you. I noticed that there's a lot of information on the internet and just out there about the ACE study. I don't know if you were a part of the ACE resilience/stress questionnaire.
Say the name again?
It's the ACE resilience/stress
No,
questionnaire.
that's not part of us. We did not study resiliency. An important and a popular subject, but not something that we studied.
You talked about the resistance to using this information, and I'm wondering if that has anything to do with the amount of money that is spent on treating these diseases.
I understand. That money is often used as an easy explanation for things. I think the issue is vastly more complex than that. Kaiser Permanente is a prepaid health insurance system. In other words, you pay your money for the entire year on day one. If we could do something to reduce utilization by 35%, we could surplus extraordinary sums of money as a profit unexpectedly. Drug companies are not relevant to a big organization like Kaiser Permanente. We have 11 million members. It's a huge operation. Okay, but I am. My example is Kaiser, which theoretically is the optimal system, you know, to recapture the financial benefits of this, hasn't touched it.
Why not? That's the follow-up question I have.
Well,
You think the insurance companies would be on this like a duck to water?
I don't know why not. Not that the validity of any of it has been denied. Most people have protected themselves far better than that by not knowing about it. We have 80 articles out in medical literature, but somehow the number of people who know about it is pretty small.
What is the best treatment for an ACE condition? Do you think that's part of the problem? Is it's really it's so comprehensive?
I think that's part of the resistance that most physicians are not sure what to do. It's an uncomfortable thing to talk about subjects that, you know, we've all been taught as children nice people don't talk about, etc. I think those are very real pieces, and the question is how to circumvent that. The reason I like using these video clips of patients making the key points that need to be made kind of forces you to remember, I mean, my God, if the patients understand it, maybe we could too.
Was there a similar research done with the tribal population? I don't remember you saying if there were any Native Americans.
No, there is not. But I'm working at very early stages with some Indian groups in Alaska and in the Midwest. I mean, if one could figure out what works in an Indian population, which is probably the most difficult population that one could think of, you know, it ought to work anywhere. So I'm hoping that we can get somewhere with that. And we're working in the realm of storytelling, creating an Indian soap opera, or hoping to create an Indian soap opera that will have illustrations of what supportive parenting looks like, what destructive parenting looks like, how they play out. If any of you have associations with the university, you have a drama department there. You have a psychology department. And those are pieces that are useful tools, and they're already getting paid by somebody. So you don't even have to worry where you're going to get the money for that.
How does the medical profession make a more streamlined collaboration with therapists to start referring immediately to therapists?
I don't have a good answer to your question. The question relates to, well, what about the role of psychotherapy in all of this, and, you know, referrals to that. What I can say is, and I would consider myself a strong believer in psychotherapy, but the problem with it is that it is an inefficient process, which is separate from, you know, quite effective, but nevertheless time-consuming, hence costly. Hence, if you don't have an insurance company to pay the bill, well, I don't have any patients telling me, you know, oh, it's okay, doctor, don't worry, I put aside $30,000 for psychotherapy. In that vein, however, two forms of treatment you should know about, think about. Medical hypnotherapy. And there's a website, the American Society of Clinical Hypnosis, and EMDR, Mind Movement Desensitization and Reprogramming. The advantage of both is that they are frequently effective. Most importantly, they are effective in very small numbers of sessions. I've had a lot of experience with one psychologist in the community that I've referred a couple of hundred patients to over the past 25 years. And I have been very impressed with what he has accomplished, oftentimes in 1 to 2 3 sessions.
Yeah, EMDR is very quick. I have clients who need a few sessions and they're done.
Yeah, and there's a website for EMDR also, if you're not familiar with these. And at those two websites you can find the names and addresses of the experienced therapists in different parts of the country.
Vince, without my being too cynical, your slide in the interview of the woman with the 3 cancers and other things takes me back to the comment I made earlier about how our country is focused on fixing things rather than preventing them. The drug companies that make medications that help cancer patients are making hundreds of billions of dollars doing that.
Sure.
If we were to cut down on the incidence of cancers and the other diseases that we know now are associated to a surprising proportion by ACE conditions, they would all go out of business. And this country will not let that happen because our economics are not based on what's good for people. It's based on what's good for the people with a lot of money.
I understand what you're saying. I don't particularly agree with the power of the statement. So.
Well, much like the gun problem, we just simply have to figure out a way to bypass some of that, because we haven't even touched yet, Dr. Politi, and I must say, in almost 40 years in public health myself, I have never seen a more important study, more important work than what you are doing. So congratulations to you. Because we haven't even touched on the, if I'm correct, the damage to DNA that can result from it.
Well,
That is a
good point. We have spoken here about the effects of adverse childhood experiences on people's emotional needs and coping mechanisms put into play to minimize those, smoking, drinking, street drugs, etc. We have spoken about the biomedical consequences. We have not spoken about the epigenetic consequences. When we planned the study in the early 90s, the word epigenetics barely existed. The field has explosively grown. That's undoubtedly an issue. I have no doubt that over the next decade or so, we're going to be hearing a lot about epigenetics. Epigenetics is to be distinguished from gene mutations. Gene mutation alters the structure of a gene and hence its function. Epigenetics alters the function of a gene, but not its structure. It's like putting an on-off switch on it. And the essence of what is being learned in epigenetics is that life experiences seem oftentimes to have the ability to turn on or off the function of the gene. We're at the very beginning of this explosive growth of knowledge, and that will be the third category by which damage occurs.
So with that, all that pain, that damage to body and mind and spirit continues not only into adulthood for these children, but into their children's children.
Into the next generation. So, clearly there is intergenerational transmission. I mean, you grow up in a household where your brother's in prison and somebody committed suicide, et cetera, obviously that's the road to intergenerational transmission. But there's a second road to intergenerational transmission, and that's through epigenetic effects.
I was making a list, and I had 8 very significant health issues on here. And I was raised in a very violent household, all those things. But I was processing of why nobody's doing anything about it. Over my lifetime, I've been to numerous doctors. I don't think there's any great big plot. Nobody's asked me ever, not one thing about my childhood or the stress in my life. All these things were independent, including 5 miscarriages that I had and a hysterectomy at age 35. So nobody ever made a connection. So I'm wondering if part of the solution is to educate the upcoming new doctors.
Yes, I think there's no question about that. And if one is going to do that, the place to start is in the first year of medical school, where it's a far more receptive audience than, say, trying to start an internship or residency when there's a fair amount of case argument that's occurred. There's no question about that. But that's easier said than done.
I understand
I
that.
mean, medical schools are commonly the most powerful part of any university, and if their mode is to resist external change, they have a lot going for that.
Hi, up here. So that question, that's exactly what we're trying to do. I'm faculty here in internal medicine, and we have two other colleagues here who are trying to train our residents. We haven't started medical school yet, but we're getting there. How to ask about ACEs, how to then deal with the patients who have been traumatized, how to talk to them about it, how to connect it to the health problem that they're having. It's really hard. Especially doctors in training want a simple fix. We had a statin, a group-related product statins. If we had a drug, they would be all over it. But if you can't tell them something easy and simple and something that makes sense to them to fix this, they want to fix things. Doctors are trained to help people and to have a solution to their problems. When you present them with something that they don't have a solution, an easy solution for, or a fairly quick solution, they get very frustrated, and that's where we are right now. But we've got a lot of people who are interested in this, and I think we're going to make a lot more progress in the future. One of the other.
Keep in mind the idea that we learned from the huge experience now about the value of collecting the information initially by an inert mechanism like a well-devised paper-based questionnaire filled out at home or on the internet. And also the idea of using video as a training tool. In my department, we had a requirement for each of the examiners once a year to submit a video of a complete history and physical of one patient. Now, again, people assure me it's crazy. Patients are not going to agree with that. Well, 92% of the people we asked agreed. We told them we'll turn the camera off during the pelvic or rectal exam and so forth. But they agreed, and we had one camera focused on the patient, one camera focused on the examiner, and it was an extraordinary teaching device. I can remember myself once seeing a video clip of me doing something that nobody in the world do I trust enough that had they told me I was doing that, I would have believed them. Absolutely not. Never would I do that in there. So the video of interviewing techniques with two cameras is a remarkably powerful tool. It's a nice present to give to a medical student or a resident to look at 20 years from now. Does that work?
We actually are working with video, so I'm really glad that you brought that up. We're using simulated patients in our sim center is what they call it. And we're also basing some of our work on what you said in your DVD that the ABA has distributed, that listening is doing. So we're trying to teach the physicians about that, and we're just, beginning that work. So.
Good. Congratulations. I think that's enormously important. Here, some sources of further information, some very interesting books that are pretty new. And if you want more information, about the ACE study, some materials are up here just